Hello and welcome everyone to the International Interprofessional Mentorship Program. My name is Kate Barlow and I am the founder and host of today's meeting. It is August 17th, 2022, and today Dr. Jennifer is here to talk about adult acute care. Please mute yourselves during the presentation. However, you can unmute yourself to ask a question at any time, or you can type your question into the chat box and I will ask Dr. Nordstrom for you. In order to receive a certificate of attendance for today, I will put a link in the chat that you will need. And please stay on the webinar until the end. We will have an optional meet and greet at the end. And thank you all so much for coming. Thank you, Jen, for coming to present for us today. We're so excited to have you.
Well, thank you for having me, Kate. I was really excited to get a chance to meet some of you and talk about a topic that is near and dear to my heart. I have had a lot of experience in acute care, so I'm very excited. As you guys might know, there are multiple settings that you have an opportunity as an occupational therapist to work in. It is so diverse that you get to kind of pick and choose a preference, or sometimes you have to find where a position is open and jump into it. And adult acute care might seem intimidating, and the hopes of my lecture today is to kind of explain to you a little bit about what to expect, what are some of the requirements, and what is the OT's role and goal throughout your time in acute care. All right, so a little bit about me, as Kate had explained. I have been an OT for 23 years. My very first job was in acute care right out of school, and that was in Connecticut, and I worked there for about 13 years, and now I work at Bay State Hospital here in Springfield, Massachusetts in acute care as well, and I am an assistant professor at American International College. So I have the best of both worlds, being able to still be a clinician as well as now an educator. So let's talk a little bit about occupational therapy and the role it has in acute care. So what I have a tendency of doing is, on a couple of these slides, you will see a barcode somewhere on the screen. You can go ahead and scan it with your phone. You can actually hold your phone up towards it as if you were to take a picture. And then this will give you access to additional information besides my PowerPoint. I have spoken with Dr. Barlow, and I will be providing her with my PDF form of the PowerPoint as well. But I think this is a great resource tool because there's always additional information that I'd love to get out there, but we wouldn't have the time to kind of go over it. So you'll see about 3 of these throughout the presentation. And I also have included links to them in the reference as well. So a little bit about the hospital setting. So it's usually located in an urban area or surrounding cities. We typically refer to our clients as patients. And honestly, in acute care, we have very little time with our patients. We have a very large patient caseload. So we pretty much do our eval, our intervention, and sometimes our discharge all at the same time. So again, you get a chance to meet with a variety of diagnoses. It is a very fast-paced environment. So if you're an adrenaline person and you like to have things that are unknown and quick, fast pace, it's great. If that's not you, don't panic. You can develop those skills over time. It is an environment that your patients are in critical care sometimes. So the type of therapy depends on the diagnosis and the condition of the patient. What I love most about acute care is that you do work very closely with your other disciplines. I do a ton of co-treats with physical therapy and speech therapy. I work very closely with the nurses as well as the doctors. As far as reimbursement, it's pretty much Medicare Part A, Medicaid, and some private insurances. Your documentation in acute care is going to be with electronic health records. All right, there are challenges in acute care. Once you get that referral for OT, you kind of come in on your day when you start working, and there's a list of patients that you are going to get on every single floor of that hospital for OT services. So typically a day looks like 13 patients for me. Of those patients, I have interventions treatments that can vary for 15 to 25 minutes, and then evaluations for 30 to 40 minutes. We pretty much split up our hospital based on diagnoses and floors, and I'll go over that with you as well. When you first start working in a hospital, you have to have an orientation to the facility itself. The building is huge. There's a lot of standards, requirements that the facility needs to make sure you know, as far as the safety of yourself, the safety of your patients, and liability, and so forth. So you have to go through an orientation with your hospital first, then you go through an orientation on the floor that you're working with. And we'll kind of tell you in a few minutes what environment is most ideal for new therapists that you'll start into, and then you progress to some specialty areas. So unfortunately, because the unknown is there and the patients are in the hospital because they're not medically stable, sometimes there's a lot of limitations in our setting. So our patients are unavailable, whether they're off the floor at a procedure or they're with another discipline, or they're getting films or x-rays. So sometimes you might set your schedule out to see so many people, but you have to quickly adjust and move around, or you might get a phone call in the middle of the day, stat, you need to reevaluate this person for discharge plans. There's pros and cons to working with multiple healthcare professionals. I love it because if I need to ask a doctor a question, a nurse a question, they're right then and there to help you. It's a very medically based environment. As far as time limitations, like I said a little bit earlier, patients are very busy. They also have family members come in. I can say we had COVID really restricted our family visitors, and that was ideal and not ideal, but it allowed for more time to see patients. But again, the patient's priority is to become medically stable. So whatever procedures and tests or medicine that they need to undergo is a priority, as well as meeting with the doctors and nurses. And then when it comes time for them to be discharged, we are in there right away to address those needs. Okay, so typically with a chart review, we'll get those physician orders. Really important with the chart reviews is, again, this is all electronic, so you have a password you could enter into it. But really, one of the biggest issues is being able to understand medical terminology, understand what that referrals order is for. It'll usually specify if it's for an evaluation, if it's for a splint, if it's for adaptive equipment. Sometimes it's broad and general based on the diagnosis. It's really important to look at the past medical history of your client, as well as their current medical status. So why were they admitted? What has their hospital course been? What have been their medications that they are currently on? How are their vitals been? Because all of that is going to influence the type of therapy and monitoring you need to do during therapy. What are the patient's precautions? Did the physician indicate any of those on your referral? Typically, we'll get weight bearing is tolerated, fall risk, but otherwise they will specify non-weight bearing. You need to research and figure out what extremity, why is it non-weight bearing, and so forth. Also, we have access through electronic records to see images and reports, as well as progress notes. You always want to check the latest note with a nurse before you even talk to the nurse. That usually will specify if there has been any issues that day. Under no circumstances are we in acute care really able to see a patient without reviewing it with the nurse first. They're the ones to let us know, nope, they're having a rough day, blood pressure is really off, we're trying to manage their medication, there's a change in cognitive status, or nope, they're great to go. They've been up to the bathroom already. They want to be discharged. So they are our go-to person right after that chart review. So it's really crucial to meet with them no matter how busy it is. They could be off the floor at a medical procedure or off the floor transporting a patient or on lunch. There is always another nurse covering who is given a report on that patient. I cannot tell you how many times a patient has now been made NPO through a verbal report, and that might not have been put in yet by the doctor, or now the patient's been put on strict bed rest because of a change of status. And so you can't always assume that those progress notes are up to date, unfortunately, because they are so busy in the hospitals. So you really want to make sure you talk with your nurse on those issues. These are just common abbreviations, again, just an extra source just to have handy. When I used this link, it was through, I gotta see what program I used it with. I think it was OT Spot, OT Potential. And so here it was created, it's a website that's created by another occupational therapist, Sarah Lyon. I love her resources. It is a paid website, but it has a wealth of information. You don't have to pay for these abbreviations. Once you click on this link, you'll be able to keep scrolling down. It might invite you to become a member, but at the very bottom is a list of abbreviations that you have access to without being a member, just so you can have handy. I found in the beginning when I first started, that was really important to be able to get those abbreviations down packed. Now with electronic medical records, abbreviations are very uniquely done. So you're gonna have to, it's another language all to itself. Typically therapy for OTs and acute care, the primary location that these are done is in the client's or the patient's room. So it's really important for you to be able to familiarize yourself with all the different types of equipment, especially bed rails, bed alarms, call bells. Usually there is a recliner in the room, and some rooms we're lucky enough to have an actual bathroom in the room, which becomes very helpful. But again, some of our beds, we have to be able to know where the locks are, how to maneuver these, and sometimes the alarms are on the actual beds themselves. They vary differently. So you do need to familiarize yourself with the equipment. Rooms are tight. Typically there's 2 patients in a room plus a family member. We usually have equipment in there like a walker that is shared between 2 patients. So anything that you use, you need to sterilize before and sterilize after. But typically all of our interventions are done in the room, which is kind of setting you up for what it would be like in their home environment. And then walking into the hallway is going to simulate walking into their hallways at home, and then stairs and so forth. We do have cases where we are actually treating our patients in the hallways. A lot of times we will get calls from the emergency room, and in doing so, they don't have a bed yet. So we will actually evaluate and treat in the hall to the best of our ability. Sometimes when we're working with a patient and their roommate is having a procedure done in the room, we'll have to bring our clients and patients out to the hall as well to work with them. Sometimes due to altered mental status or safety concerns, you will find your clients sitting in the hallway at the nurse's station. Sorry, we're trying to get them discharged, but we can't have restraints or and so we kind of have to have them out in public. So we could say, nope, don't get up. You have to stay in your chair, even with bed alarms. So you will do therapy in the hallways for that as well. This isn't as often, but sometimes too, when we're concerned about somebody and we co-treat with physical therapy, we'll both work together where we'll take them down the hall. Physical therapy will work with them on stairs, and I could be doing some cognitive vision and balance with them at the same time to determine if they're going to be able to go home alone. In cases, we do have a rehab gym. This lecture is solely for adults, but just a little brief input. When you do work in acute care, you have the opportunity to work with babies all the way up to geriatrics. Typically, it's on the orthopedic floor. There is some gym area where we're able to meet with our patients. Might have stairs in there, might have parallel bars, a very small mat. And then actually where I work, I'm very fortunate. We have a car simulator, so we're able to do transfers in and out with all of our patients. So we do not have rehab gyms on every floor. It's one specific floor, and it's not where our office space is. Again, remember, hospitals are huge. They're usually multiple wings at one time, but this is ideal to be able to kind of get in because you're able to see how your client can do with other stimulation, socialization, and other equipment that we can get a client to use that we couldn't necessarily get them to use inside their room. So these are handy to be able to do and have access to. So when we talk about our occupational therapy evaluations, again, I told you my eval is usually within 30 to 40 minutes. So in that time, I do work on my occupational profile. I've already done my chart reviews. So I basically have a picture of my client before I even go into that room. I know their diagnosis, I know their precautions, I know their age, I know their gender, I know what the goal is. I read case management's notes, so I'm going to know that we're trying to get this person home or to a skilled nursing facility, or they don't have any insurance and there's nowhere for them to go. I also know a little bit about baseline information, but not a ton, and it's not always accurate. So when I go in and meet the client, I want to know, how are they doing cognitive wise? Do they know where they are? Do they know why they're there? Can they provide me with their previous level of information? What are their capabilities as far as body function, structures? What are the limitations of them? What are their performance skills? Cognition wise, are they alert and oriented? Can they follow one-step commands? Can they physically move extremities? I test their strength. I do a quick screen. I test their sitting balance if they're allowed to get out of bed. I test their standing balance, so we can do a transfer as long as their weight bearing is tolerated. And if I'm not sure they have been in bed rest for a while, I'll usually co-treat with physical therapy for first time out of bed. If they've been in bed a long time, you have to monitor them. Always check pain before they get out of bed, once they are in a new position. And that's pretty much in a nutshell. So I can get a true understanding of who they live with, what they're capable of doing, what were their jobs beforehand, and what are their goals. So typically their goal is to get up out of bed. They want to go to the bathroom. They want to get a new Johnny on. They want to get new clothes on. And so those are their priorities. We are the ones that will determine, okay, this person can get up, this person lives alone, this person lives with family, this person has stairs. We kind of have to be that investigator and predictor of safety for them when it comes time to leave. Just going the other way. So with that said, here are some common diagnoses that you will see in acute care. All right. And so I kind of explained to you also early on that when you are new to this environment, you're not going to be thrown into every single floor in the hospital. We're going to start you usually off in orthopedics. That is a floor that will have a rehab gym. You will see hip surgeries, you'll see hip replacements, you'll see knee surgeries, you'll see shoulder surgeries, rotator cuff tear surgeries, fractures, hands, lower extremity fractures. And so this particular environment is crucial because most of these patients, some of them are there for one day. They actually come in for a hip replacement or knee surgery or rotator cuff tear. They've already had education before coming to surgery. So they already have equipment that had to be ordered ahead of time. And you come in and you assess them and you teach them how to do their ADLs, go over their precautions, any exercises, and you prepare them for home with home services or outpatient. Then you have some patients that came in due to trauma who had no training whatsoever, could have been in a motor vehicle accident and have a hip fracture or a wrist fracture on the right arm, a left shoulder fracture. So weight-bearing precautions and contraindications are quite challenging. Those patients might be in the hospital for a day, all the way up to a week, depending on the severity. We really try in the hospital, once they are medically stable and able to leave, we get them to a facility. We as OTs make the recommendations. If we do not think somebody is safe to go home, we document it, we make it quite clear, we talk with case management, and we really push for a facility for them to go to. A lot of our clients lately, there's no rooms, there's no beds. So my eval machine and quick interventions are now turning into more of a long-term rehab because there's nowhere for them to go. So we actually get to do a little bit more therapy lately due to COVID than usual. But again, in this situation, you as a therapist need to know where the injury is. You need to know the precautions specifically to those injuries. So we have for hips, our anterior and posterior precautions. We have to teach our clients dressing techniques, the do's and don'ts. We have to also make recommendations for home. What does your home look like? Do you have a raised seat? Is it a low seat? Do you have a tub bench? Who lives with you? Do you have to go upstairs to go to a full bathroom? All these questions. We have braces that we have to teach our clients to put on and off. They can take them off when they're getting washed and dressed. Again, depends on the diagnosis and the doctor's permission, but they are so afraid to take braces off. And as long as we teach them properly how to do it or educate family and so forth. Even simple things of the bottom right corner with a right wrist or thumb fracture. Patients that use that dominant hand and still try to bear weight, we're constantly educating them on those. Typically after the orthopedic floor, you'll be there for a couple of weeks until you get to be really comfortable and good. And then you will then probably most likely progress to the neurology floor. Here, this is where you're going to see strokes and CVAs and spinal cord injuries. So it's really important that you understand where that infarct is in the brain and how it is going to impact your client. Is it going to cause left-sided weakness, right-sided weakness? Is it going to cause visual deficits? Is it going to cause visual spatial awareness issues, sensory awareness? I can't tell you how many times I'm the first person and the patient has been in the hospital for 3 days that I'm telling them they have double vision. Neurologists have picked up on it, but nurses don't, or they can't see the whole left side of a room, and I'm educating nurses. As far as spinal cord injury, there's really important things for you to realize and remember. Most of those there are strict spine precautions depending on the severity of the procedure and the level. So you need to know log roll. You need to know no bending, no twisting, no lifting, BLT. Some patients have to have braces on, whether they're cervical, thoracic braces. They're all different types. And if you get an order and it says cervical brace on at all times and you show up and the brace is off, you are not going to treat that patient. You need to clarify and find out if that was removed by the patient because they didn't realize it or the doctor discharged those orders. Most of the time, patients remove equipment because it's uncomfortable or they don't know what's going on. So you have to be very careful. As far as braces, if you're not familiar with them, you need to make sure that you have a therapist there to show you how to get those on and off. Most of the time, braces are put on. They can be removed. The trunk braces can be removed if allowed, and the doctor permits it for washing and self-care, and then needs to be reapplied, and then clothing goes on over that. So again, you'll also have craniotomies, altered mental status clients, clients that had a lack of oxygen to their brain. So this particular floor, you'll see a lot with your neurologist, your medical team, your residents, and your rehab potential candidates to rehab facilities will come and meet and talk with you as well to see if they are a good candidate for acute inpatient rehab at a facility or subacute or home or outpatient. Once you've conquered this, you'll most likely end up on a cardiology floor. And again, these are not ICU yet, but this particular floor will have, you need to know your sternal precautions, your cardiac precautions right after surgery. So you really need to familiarize yourself with a CABG, heart attack, angina, pacemakers, defibrillators, coronary artery disease, myocardial infarcts. You'll need to make sure that you understand when there's a graft taken for a CABG, how many grafts were removed. Also, where did they get the graft from? Did they take it from your client's thigh or did they take it from your client's arm? Because that will impact their ability to move around. A lot of times our clients will have pillows, special pillows for when they cough because of that chest surgery, if they had surgery. You're unable to do some sternal precautions. You guys definitely need to make sure that you know is that your client cannot lift more than 5 pounds. 5 pounds is not a lot, right? So think about how often they go to grab the bar rail to pull themselves over. They can't do that anymore. All right. They have to really work more on their lower extremity and their trunk. You really can't have that rib cage into like scapular protraction and retraction too much with both arms. You really have to make sure that they don't push to get out of bed. We always recommend push off the bed with your arms. Well, guess what? It's different for cardiac patients. You also have to remember they're most likely on monitors and Holter monitors. So you want to regulate and see what their heart rate is and their rhythm is, and even blood pressure before getting out of bed, sitting up at the edge of the bed, and then standing. Because sometimes these patients have a high fluctuation in heart rate that the doctors want to make sure does not go above a certain number. And so that's a precaution that you need to make sure you maintain. Also, when it comes to ADLs, you have to make sure that they're not stretching both arms out at the same time, as that could be painful to the injury site for surgery candidates. So those females that, or anyone that needs to put a bra on, you want to make sure they fasten it to the front. And I actually tell them just don't even bother at first. But again, some people have a preference to certain clothing, anything that they have to do with some twisting, always have them dress in front of them and then bring it around. Also, you always want to make sure that they take frequent rest breaks, deep breathing. Most clients are very anxious to get up, but also then very nervous that something's going to happen. So you want to provide them with that empathy, that encouragement. But again, it's not a fast-paced therapy. Endurance can be an issue as well. Some hospitals have what we call general floors. Those can be a medical floor, it could be a surgical floor. And so here you will see a variety of patients, a lot of our emphysema clients, COPD. Sometimes on surgical, you'll have amputations. You might have UTI patients, you might have burns, you might have wounds, even some light altered mental status, even though they might not need to go to the neuro floor, they might go to a general floor. So this floor has a variety of diagnosis. We also, some places have an oncology floor itself. We have that at our place, but sometimes they're also put into this. This is another typical floor that you will then be addressing because it is a nice variety of patients. Again, everything stays the same as far as our evals interventions, but you do need to know the restrictions and complications that might arise with this. A lot of times also our clients that do not have insurance will be transferred to this floor to seek out their full rehab here at the hospital before they can go home or to a group home or to a homeless shelter.
Excuse me, Jen, one question. Emmanuel has a question that he has his hand up. But
Okay.
you can go ahead and take yourself off mute, Emmanuel.
Okay. I just wanted to ask regarding can you hear me?
Yes, we can hear you just fine.
Oh, I can hear you.
Yeah, regarding the cardiac patients you spoke about, in terms of a bed transfer and discouraging pushing up from the bed, is there, what other options, like what is the suggestion? How do you promote? Yes.
Yep, good question. So typically, these patients were moving before coming into the hospital, typically. So what we try to do is for these particular patients, when getting up to the side of the bed, we might have them actually have the head of the bed elevated at first, right? Because before they go home, we'll want it down to simulate their home, but head of the bed up, have them bring their legs over and really try to use their core muscles. We'll provide the support on their back initially. Once they start to get comfortable, they can, maneuver and hold themselves up a little bit, but they just can't push. So to get them to stand, we have to make sure they scoot, right? So you can scoot yourself without using your hands. You're using mostly your lower body. We want them to have their feet flat on the floor. Sometimes we'll raise the bed up a little bit higher for them for the first initial attempts, and then really work on leaning forward and then kind of getting the momentum to come up. We will have a gait belt on them to hold support there. You never want to pull on the arms. There is a video on here that I ended up getting on a transfer, and I'm going to critique it. But really, once the patient is up, they are able to use a walker. The walker is for stability. It's not for them to put full force into, because they really should be able to use their legs. If a client is unable to do this, is unable to get up without a ton of help, then there'll be a Hoyer lift transfer over into the bed initially. But most of the clients, we start a transfer as early as ICU. And you just we just have to be very creative. Typically, those beds will go into a sitting position. Once they go onto a regular floor, again, we'll work with sit to stand with physical therapy and maybe some side steps. And then as they progress, we can continue. But you really want to make sure that those clients are not pulling themselves over. You know how we say to our general debilitated clients, okay, grab the arm rail, pull yourself over. We won't say that for these specific patients.
Can we also use the technology of the bed, in terms of putting them in a more upright position to aid sit to stand? Lovely.
Yep.
Yeah.
Yep.
Okay.
All of those.
Okay.
So you will get an order. Nursing will tell you too. Most of the time, there should not be a restriction for how high the bed can go. In ICU, there might be, just because they really can't move too much with, depending if they haven't been extubated and so forth. But typically, they will start in ICU elevating that bed to 45 degrees, to 60 degrees, and to 90 degrees. They're going to monitor the blood pressure. They're going to monitor to make sure their vitals are stable before they go onto a regular floor.
Thank you very much.
Oh, you're welcome, Emmanuel. Here is another site. This particular site just gives you some adult diagnoses. What I like about this one is you're actually able to click on. So this is a site, it's a free website, by the way, and it's all things OT. And somebody created this. It has resources, it has OT fundamentals, breaks down pediatrics, adults, and some continuing education. This particular link will bring you to a series of diagnoses that then you can click on, and they'll have additional information. And so in acute care, there is a ton of diagnoses that you're going to get. That's why you really will be trained like one diagnosis, one floor at a time, so you can familiarize yourself with that. Once you've met the competencies, you'll go to another floor. But this is just something to give you access to so that you can have resources at your fingertips. So once you're done with your training on all of your typical floors, you get to venture into what we call intensive care unit. As you can see here, there is a lot of equipment. This particular floor provides the most complex care for your clients. They are critically ill. We really need to make sure that as an occupational therapist, you are trained in and oriented to the ICU itself, as far as the medical equipment, as far as medications, precautions, contraindications, IVs, and leads. There's certain lines that are put into your arm, into your chest, that limit you from lifting your arm. You work very closely with nursing and sometimes respiratory therapists. Even though your clients are hooked up to a ton of machines, including a ventilator, a breathing machine, you still can get them up. We still can transfer them. I know it's very intimidating, but you will learn how to maneuver the lines, how we're able to shut some, again, once you're trained, some settings for the blood pressure and so forth, we can disconnect and then reconnect. We never disconnect respirators, ventilators. These are just vital leads that we can touch. Any IVs that are in the way, only nursing can come in and take some of those off. So usually we come in, we'll do some ADLs, some sponge bathing, have them sit upright. And then PT, physical therapy, will join me, and then we'll sit them up at the edge. And honestly, just getting a person used to being in a different position without the bed supporting them is therapy, just the start of therapy. And how long they can sit upright, how long their body can tolerate it. Are they desatting? Is their oxygen levels going down? Is their heart rate going up? All of the blood pressure dropping, they are critically ill. So when we come in, we're in the early stages. We will evaluate. We might show positioning recommendations. We might start to do some exercises. We might make recommendations when family comes in to only go on a certain side or switch sides to encourage some head movement. Remember, because of the ventilator, we're very limited where all the tubes of a lot of motion. These beds are specialty beds. They're air pressure beds, so we don't have to worry about sores and wounds. This can be a scary environment. A lot of times your patients are put on medications so that they don't move, that they don't get up. And so you have to correlate your therapy with them. But there is research and evidence-based research that moving your clients as early in ICU can decrease their length of stay, increase their progress. But again, we're not doing any jumping jacks here. It's a very slow environment. It is just initial OT introduction with PT, initial movement. Once they progress to another floor and some of this equipment is removed, we'll be able to do a lot more. But with that said, it doesn't mean that if you go in and you see someone on a ventilator that you can't touch them and you can't move them and you can't do therapy with them. And so that's one of the misconceptions. They're too unstable for you to go in. You need to learn that that's okay. You need to learn the equipment. You need to feel comfortable maneuvering the equipment. When the alarms go off, you need to know what that means. And so this is one of the very last units that you will be introduced to in acute care because of the intensity and the equipment. So again, these are just some overall views. My PowerPoint isn't going to make you acute care ready. It's just going to prepare you for some expectations. Even now that I've been doing this for 15 years, there's always something new that I'm learning and discovering. So you might say, okay, so I've got the different diagnoses. What does your interventions look like? All right. And this is really important because my interventions are going to be quick, but they're going to be therapeutic. And my interventions are going to be what my client wants to do. If my client wants to go home and they live alone and they're unsafe and unsteady, I have to make the judgment call and say, yes, you can go home, or no, you can't. I have to explain to them you need therapy and why they need therapy, and you need acute versus subacute. I will work with them in their rooms. Typically, it's a hospital gown and so forth. I'm actually going to show you some of the different interventions coming up. We do allow animals to come in. It is a rare occasion, but when COVID was going on and it was at its extreme, we couldn't. But we do have some dogs that help our patients with anxiety, and they are allowed to come in, but then we have to remove the roommate and we have to sterilize everything. And then they have to clean everything before the roommate can come in. We also have family that comes in that we can either educate, train, or sometimes if it's not a healthy environment, we might have to ask them to remove themselves so we can work with them if it's too much of a distraction. So let's talk about some type of interventions. Keeping track of time. Education is huge for us. All right. We are educating our clients on what we do as an OT. They don't know what OT is. They know PT. They know nursing, speech pathology they need help with, but we need to explain what we do and why we're there and what the doctors want from us. Sometimes they don't know where they are, so we're going to go over orientation information with them. We're going to go over their diagnosis, why they're there. What does that mean? Do they understand it? Do you know your precautions? If they don't, you educate them on the precautions, and then you keep reviewing it with them throughout your session. We'll always try some type of ADL for my interventions, whether it's grooming, and we'll get through that next, whether it's at bedside, new ways to do things, one-handed techniques. We will also go over different types of equipment. A lot of times they don't even know how to use the bed. They don't even know how to use the call bell. right? So some basic things, think about it, for them to need to the nurse because of pain or emergency, that's a priority, the call bell. Even their oxygen, putting it on and off. Sometimes they were itchy and they pulled it off and they forget it's off. How do they put it back on? Even masks. Our clients have to wear face masks when they exit their room. Even donning and doffing those can be challenging one-handed or depending on their situation. And we provide a ton of family education. I feel every therapy session, I am educating probably more than anything else. And I need to make sure that they have insight, and that if they don't want to go to rehab, but we really recommend it, that we can kind of show them. And I allow them to not do as well, so they can see you couldn't get out of bed. How are you going to get out of bed at home alone? You were unable to bend forward without, getting dizzy. How are you going to do that at home? So sometimes that also has to take place to allow the education to kind of sink in. Getting that right grade of an activity with your client is really crucial. All right, as far as ADLs, they get meals brought to them 3 times a day, as long as they're not NPO, and that means nothing by mouth. Very important that if someone has to can have anything by mouth. If it is NPO, that means nothing by mouth. That means no water, even brushing their teeth. Or if they have a puree diet, and you're going to be seeing them for a meal, sometimes those trays are not correct. Or sometimes a family member comes in and brings something to drink and it's not puree. Puree means it's thickened. You have to know how to change that consistency to make sure it's thick. I can't tell you how many patients that are diabetic and they're not getting a diabetic menu. So again, these are things that when it comes to feeding, not only bringing the food to their mouth and being able to drink, we also have to make sure they can fill out a menu. They can answer a phone call to tell them what they want to eat. They can actually see their food. They can find their food. They can open containers. As far as dressing, I get the chance to work with hospital gowns a majority of the time for my patients that are going to be there for more than one day. So they have to get Johnny's on, they have to get Johnny hospital pants on and hospital socks on. And depends for underwear or pull-ups as well. Sometimes we have these amazing netted underwear, and I'm being sarcastic. They're not amazing at all, but it's the closest thing to underwear that we can give our patients. Now, on my ortho floors or my patients that are being discharged that day, they get to put on their regular clothes and they are so excited. They feel human again. And I have to go over their dressing techniques, their precautions, maintaining it, any equipment that they need to use. And so again, that education and that ADL component ties in together really nicely with that. And just putting on a shirt, underwear, and shorts from home, they feel like a new person. So you have to remember, sometimes those hospital clothes can psychologically impact someone's progression with therapy. Grooming, we're going to be working on brushing your teeth, helping you with your dentures. We're going to be doing that at bedside, at the edge of the bed, or into the bathroom. Typically, I'm very fortunate that most of my floors have a bathroom in their room. Sometimes we have a commode that we bring, but things that you guys have to realize too for toileting. Sometimes patients are at bed rest. Sometimes they have Foley's. Sometimes they have PureWicks. PureWicks is a little bit of a newer technology. So the Foley goes inside the client for urination, but now they have for females, it's almost like a pad that's just resting down by their vagina area, and it suctions the urine. And it's been a great device because it can be removed and put there. It prevents infections and leakage of urine. So that's something. We have Texas Cap, which are condom-like urine Foley catheters that you have to be very careful when your client is moving if it is to fall off. You also have bedpans. Then we have bedside commodes as long as they're able to get out of bed. And then the biggest goal is getting them to the actual bathroom. We usually have bars in the bathroom, raised toilet seats, and here's where you can educate them on safe transfers, but also what devices they might need in their home as well. This is the video I'm not exactly impressed with, but this is my closest to get you for transfers. So we do not transfer our clients this way, but this is just to show you a transfer from chair to bed. We do use a gait belt, or we have two of us on either side, depending on what their transfer status is, for support. And they use a walker or a cane or a hemi walker. We try to use gait belts as much as possible. They're in every single room, and we're able to sterilize them after each use. Bed mobility is considered a transfer, rolling, supine to sit, and then wheelchairs. We also have patients being discharged, so we'll do an evaluation, get them dressed, get them in and out of the wheelchair, make sure they can use the wheelchair. We get them on and off stretchers before they can go for procedures. So if I'm on a floor and I know I have an eval and I recognize we're all color-based, right? So therapy is gray, and then our nurses are blue, our PCTs are maroon. And so if I see someone from transportation coming in green and I hear the room and they're coming in my room, I'm going to get right in there before they do, let the patient know after I ask the nurse, get them ready, help them with that transfer to the stretcher, or it could be bed rest patients. So we just got to scoot them over, or we can have them stand. So you recognize what's going on, and that might be my therapy session for that day. So those are just types of mobility that we do utilize. As far as durable medical equipment, our patients are able to get okay, so right here is what we call a leg lifter in blue. We're able to give those out for free. We used to give out all this other equipment, but we can't anymore. So what we do is we show pictures. I usually get the best price on Amazon, print it out, show the family the pictures, and then I demonstrate with a sample of equipment, and then recommend they purchase them. Things that we can give them is the leg lifter, a knee spreader, which is like a pillow that goes in between their legs, and any braces they get. But we most likely when they're discharged, or before they come, they have the equipment if they had training. But these are just some types of equipment. If they're going home, I'm going to educate them on other options as well for devices. So what are the pros and cons? I always think that when you're considering a job or a position in this field, for me, these are my pros and my cons. You might come up with other ones as well. But what some pros are is that there is a nice variety of patients. You are always going to have a ton of people, different diagnoses, different ages. You're never going to be bored. And so it's really a great way to start your career with getting that basics. Remember, we're in just for a little bit. So you got to know the medical conditions, the precautions, you get that initial treatment, you got to predict, can they go home? Can they go to rehab? And you do a little therapy at the hospital. You have a wonderful interdisciplinary team that you get to work very closely with. You're always busy. I can't tell you how many steps I put in a day. It justifies me not going to the gym, but I do still need to do that. It's a very rewarding job. We have sad patients, and we have exciting patients, and we have shocking patients, and I cry and I smile on a regular basis, but I truly love what I do. There's consistent hours. There's always extra hours. They can have you stay as late as they need you. There's never enough of us to do all that's required. So you do have to make sure you restrict yourself and you don't overdo it. Some cons is that it is so fast paced. Some people, it's too fast paced for them. I am an adrenaline junkie. I like a lot of things happening at once. I don't know when that started because I didn't grow up that way. But once I entered acute care, I was just in heaven. Your caseload is very large. I have a minimum of 13 patients a day. That's a lot. It's a lot to see, to treat, to evaluate, and then to constantly go to all different floors, all in 8 hours. Sometimes we sacrifice our lunch. It might be 15 minutes if we can get it. And that's something I'm really working on, trying to make sure I don't do that. Sometimes we stay too late. I'm trying to work on that as well. I'm per diem. So I've been doing this for so many years that I kind of know the routine, but I see a lot of new grads come in super early, stay really late because they're trying to learn. And that balance is something you're going to have to do. You don't get a great rapport with your patients because you might only see them once. When I get to see my patients second or third time, it's amazing, but it's not likely. You do feel like an evaluation machine. There is a lot that you do need to know. Your precautions, your contraindications, your diagnosis. If you don't know something, don't fake it, because that patient's safety is in your hands. So you need to make sure that you're comfortable in your setting, you're comfortable with the diagnosis. And if you're not, you need to talk to your supervisor. You really need to make sure that you use good ethical values and core smart clinical reasoning and good decisions. I know that everybody wants to do a great job and doesn't want to make anybody upset and doesn't want people to know that they might not know something. But the worst thing you can do is fake it till you make it in acute care. That's not the philosophy. You need to know everything. And if you don't, you need to find out and you need to clarify it because it's a very intense environment. And it's crucial that you are on your A game pretty much every day. So here I have included some of those references. So if you were unable to scan them at the time, the links are all here for you to access them as well. And I was going to kind of leave this as an opportunity for any questions. If I didn't cover something or you needed more clarification, I would love to answer anything that you might have.
Thank you so much, Jen. If anyone has a question, please go ahead and put your hand up and I'll call on you, or you can type it into the chat box. When you were talking about the ICU, I know that when my father was in ICU and I saw all the machines and all the tubes, I took a picture because I was so overwhelmed. I'd never really been in an ICU and it was scary to me, like especially being an OT for over 20 years and never having been in that situation. I was so scared. I took a picture and I'm like, oh, I should, show this for our students. So I do have that picture because it was just really coming from a pediatric background. It was just shocking, all of the tubes and everything. So I admire the work that you do. It is definitely a lot to see for the first time, I think.
I know. And I hope I was able to give you guys a little bit of everything. Just like any setting, there's certain evaluations that you use, certain screenings that you use, certain documentation, certain wordings that you use. Everything for us is typed. My evals are you click a button and you do some typing, but you mostly click everything. My SOAP notes are done on a regular basis after every therapy session, and it's a typical SOAP that I have to type. There is no word check or spell check for electronic medical records, so you want to make sure you review your work, because at the end of the day, sometimes what you think makes sense and then you read it again, it doesn't. It can be scary, but it can be so amazing and so rewarding at the same time. And again, what's nice about this is just the adult version. There is also another whole area for acute care, for NICU, for neonatal and pediatric ICU and pediatrics.
So there is a question from Tiffany in the chat box, and it says, any tips on how to prevent injuries during transfer, wrist or back injuries?
Can you just clarify, you're referring to the patient, correct? On how to cause injury to the patient?
For the OT, she said.
Oh, for the OT. Okay. So really important. When you're doing a transfer, you want to make sure that your patient is in the ideal position before any transfer, right? So their feet have to be flat on the floor. They have to be fully able to sit upright or lean forward without losing complete balance, right? So we as OTs have terms that are min assist. We help a little bit, mod assist. We do 50%, they do 50%, max assist. We do most of the work, right? And then total assist is a Hoyer lift. You should not be transferring anyone that's a Hoyer lift. Your patients, if you have a gait belt, some people bring in their own gait belts to the hospital. if there isn't one there. I highly recommend you using a gait belt. Do not have your clients grab at you, pull on your neck, pull on your arms when you do a transfer. Your body mechanics is the most important thing. You should always be facing your client straight on. Your knees should be bent. You should not be bending at your back. You should be going down on your knees and keeping almost a straight back. If you go to transfer to get that patient to try to stand up and it's not successful, bring them back down. That is not a transfer that you're going to be able to do by yourself. So you're going to need to get help from the nurse, the PCT, or another therapist to attempt it again. If you are able to get them up safely, okay, your knees should still be bent. You should be able to pivot. You want whatever they're going to be right next to the bed, right at an angle that it's not a ton of movement, right? You don't want the wheelchair all the way where they have to take steps their first time to get up, or the chair. Everything should be very close to you. We also have sliding boards that if a patient is too difficult to lift up and have them put weight in their legs for you, you can have them use a sliding board to get across. So you have to make sure that you're in good health and good condition to be able to lift, but you should not be doing all the work by yourself, because day in and day out, that's going to put a toll on you. So make sure their feet are on the floor. They can follow directions. You have safe equipment, and wherever they're going to is very close. I hope that helps.
Thank you, Jen. We do have another question, and that is that documentation is taking up most of their time and parts of the working day. Do you have any tips and recommendations on how to save time on documentation?
So there's a couple of rules of thumb here, right? So when you're brand new, or you're new at doing things, what I usually do is I have a piece of paper that I carry with me and I fold it literally into parts. So I will take a paper and literally fold it. And then every patient, and when I open it up, it makes squares. I put every patient that I'm going to see in here. I write their room number, their diagnosis, their age, their precautions, and then when I'm in the room, I write what I've done. So min assist, bed mobility, mod assist, upper body ADLs. I specifically put things in a direct quote. I have been doing this so long that I can go an entire day and see patients and have my cheat sheets and then do my notes at the end of the day. I don't recommend doing that when you're fairly new. I recommend that you might take one or two patients, write it down, and then go right in and do your note. Don't wait, because you might get confused on the patients. So typically what I'll do is I'll go in, I'll see my patient, and then I'll go right to the computer, open it up, and then start my S, my O, my A, my P. I might not finish it, but I put a majority of what I want in there as quickly as possible. Sometimes my notes are going to be the same, right? So I've come up with an S that was appropriate during therapy. My O is going to start off with, when I approached them, where they were positioned, if they were oriented, and then I go right into education, whatever I provided, ADLs, mobility, cognition, my A, and then my A is going to be just an overall assessment. Do they seem to understand the education? Am I concerned about safety? Do they have good family support? And then my plan is continue with OT for ADLs, blah, 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 blah. So sometimes my note has similar information, and I get really fast at typing, and we do a lot of abbreviations. So I recommend when you first start off, see 1 patient to 2 patients, get that note done. Don't sit there for too long. If you're sitting there and you cannot get what you want to say, then your mind isn't there yet. You might need to write down what you did that therapy session, go to the next patient, and then come out and do it. Some people save half the morning before lunch and they get all those in, because case management and everybody wants to see your notes. And so you also have to have it within a certain amount of time. So you have to keep track of the times when you go in to see, because you might need to adjust the times. So be concise, be specific, give assist levels. Do you recommend further therapy? And if so, why? Do you recommend they go home? Do they need 24-hour supervision? put specific information that, because your job is to determine if they're safe to be discharged and where they're going to be discharged to, on top of everything else. So your notes shouldn't be too long. They should have specific information on what you did and where they should be going. And if you don't want them to go somewhere, you need to specify why. And your evaluation should, again, if it's electronic, it's really the fastest format because you just click buttons. You do have to write a little bit, but not as much as a note.
Thank you, Jen. All right, just for time, this will be the last question, but any future questions after this, you can email me and I will forward to Jen. Mikey, you have the floor. What is your question? You can take yourself off mute.
Greetings, Dr. Kate. Mine, it's not like a question, but I wanted to say, like, I've joined the talk a little bit late, but from what I'm gathering is that you guys are quite advanced, and like where we are right now in Kenya. One thing that I've come to realize is that that has shocked me is that you guys give out free kind of like assistive devices for your patients. And over here, it is not possible for us. And also the way we operate in our ICUs is quite different. We are learning a lot from you guys. And I believe that this talk is going to change a lot from this other side in Kenya. Yeah, thank you very much.
Nice. I want to clarify, Mike, when I say we give out, so we don't, so I'm saying it correctly that we don't charge for only 2 devices, and that is the leg lifter and the knee spreader. But we used to give a whole kit out, and it still would get charged, but it wouldn't be a lot of money, and it would go over the entire hospital bill, whatever they had for insurance. But the hospital unfortunately was losing money with that. And so that's why they took that away from us, which was really tough. Just so you know, there's many ways to be creative and make your own equipment with patients and so forth, that if someone can't get equipment, I use household items to educate them on it. But unfortunately, money is getting really difficult where we can't give what we used to be able to give. And so that is across the board. I'm seeing it more. But I'm glad you found this helpful and beneficial. And, it doesn't matter where you are at what stage of rehab, as long as you're still looking to do what's best for your patient and get them moving and get them to reach their goals. That's the most important thing.
Thank you so much, Jen. This was wonderful. Any future questions, you can go ahead and email me and I will forward them to Jen. This was a wonderful presentation, Dr. Nordstrom. Thank you so much.
You're welcome. Good luck, everyone.